Welcome to Learning Nebula, where medical concepts become visual and crystal clear.
Welcome back to the deep dive. We're trying something a little different today. Usually we are wading through a stack of articles, maybe tearing into a new book, but today we are kind of stepping into a virtual classroom.
Yeah, that's a good way to put it.
We've got our hands on a specific set of slides lecture material, really, and it's titled The Art of the Medical History, a structured guide to the foundation of diagnosis.
Yeah, it's a really fascinating deck. I mean, it sounds a bit dry on the surface, right? Medical history. But
Right.
this is essentially the manual for how doctors are trained to think. It's the bridge between a patient saying, I don't feel good, and a doctor saying, you have this specific disease.
Exactly. So we're going to act as your teaching assistants for this session.
Well-
We'll walk through it slide by slide, but we're not just, reading the bullet points. We want to understand the logic behind it.
The why.
The why. So imagine the lights are dimmed, the projector is humming, and we're looking at slide 1.
The title slide, it's very clean, just a minimalist line drawing of a stethoscope head. Sets a very specific tone right away.
Which is funny because the whole point of this deck seems to be that you don't even need a stethoscope yet.
Not at all.
This is all about talking.
That is the key insight right off the bat. The subtitle calls this the foundation of diagnosis.
Yeah.
But there's a phrase here on slide 1 that I think is really important. It calls the medical history, or anamnesis, the technical Greek term listed here. It calls it the first therapeutic act.
The first therapeutic act.
Out.
That's interesting. I think most patients feel like the therapy starts when they get a pill or, I don't know, a surgery.
Of course.
But this slide is arguing that the conversation is the treatment.
In a way, yeah. It's about validation. It's the moment the patient's chaotic experience gets organized into a coherent story. And if you mess this part up, if you don't transform that story into accurate data, everything that follows is just. It's on shaky ground.
The cornerstone.
The cornerstone of patient care, just like the slide says.
Okay, so our mission today is learning how to build that foundation. Let's click forward. Slide 2. We're moving past the title to the objectives.
The header is more than questions, the 4 objectives of history taking.
And visually, it's a profile of a human head with these nodes connecting in the brain. It's showing that we're not just collecting a list of random complaints.
No, you're building a network of information.
Okay, so the slide lists 4 objectives. The first one seems obvious. Discover symptoms.
It sounds simple, but it's actually pretty tricky. Discovering means uncovering the full range of what the patient is feeling. Patients often downplay things or they forget to mention something. Your job is to be an investigator.
To bring those sensations to light.
Exactly. Then the second objective is where it gets more technical. Obtain accurate quantitative descriptions. It says we need to move beyond vague statements to precise details.
This feels like the difference between just a chat and a real medical history.
It is. If a patient says, I've been coughing a lot, that's, scientifically speaking, useless data.
Because a lot is totally subjective.
Precisely. Does a lot mean 3 times a day or every 2 minutes? You have to turn that subjective experience into objective quantities. I cough every 20 minutes is data. I cough a lot is just a feeling. We need the measurement.
That makes perfect sense. Okay, objective 3. Secure a precise chronology of events.
The timeline. This is huge. Diseases are stories, right? They have a beginning, a middle, and an end. The slide really emphasizes establishing a clear timeline if you get the order of events wrong.
Like thinking the fever started before the rash when it was actually after.
Yes, you could completely misdiagnose the whole case.
And the 4th objective listed here, determine the impact. The text says, understand how the illness has changed the patient's life.
This is the empathy piece, but it's also diagnostic. The same symptom means totally different things to different people. A concert pianist says her finger feels a little stiff.
Catastrophe.
It's a catastrophe. If I say my finger feels stiff, it's probably nothing. The impact tells you the severity relative to that person's actual life.
Okay, so that context changes everything. Let's move to slide 3. This one's titled The Dynamic Process of Clinical Reasoning. This is where we get into the doctor's head.
Yeah, I love this graphic. It's a diagram in the center, a circle of arrows connecting 3 steps. But the really important note is in the middle. Simultaneous steps.
Wow. That sounds incredibly stressful. So you're not doing step 1, then step 2.
No, and that's why this training is so critical. You are doing 3 things at once. First, acquiring data. That's just listening. Second, evaluating data. Is this person reliable? Are they confused? You're assessing credibility.
And the third step in that circle is generating hypotheses.
Right, so while you are listening, you're already guessing. Formulating and refining diagnostic possibilities in real time.
And the slide breaks these hypotheses down into 3 types. This is really granular. First, the anatomic hypothesis.
Basically, where is the problem? Is it the lung, the chest wall, the heart? You're literally mapping the geography of the body.
And the physiologic hypothesis.
What is the pathophysiology, which just means what's the mechanism going wrong? Is it inflammation, a blockage, an infection? You're figuring out the how.
And then finally, the diagnostic hypothesis.
And that's the name of the disease. What diseases account for this? So in real time, you're thinking, okay, it's in the lung anatomic, it's an infection physiologic, so it might be an ammonia diagnostic. All while you're nodding and asking, and then what happened?
That is a serious amount of mental gymnastics. You have to be present for the person, but your brain is running this whole other algorithm in the background.
It is parallel processing, and you can't even start that process until you've set the stage, which brings us to slide 4.
Preparing the stage for trust and disclosure. This slide has 4 quadrants, and it says the environment is an extension of your professional self.
That's a heavy statement. It implies that a messy room suggests a messy mind to the patient.
Okay, let's look at these quadrants. Top left is the room. It's emphasizing privacy, professional decor.
It's about safety. I mean, if you're going to ask someone about their substance use or their sexual history, you can't have the door propped open with people walking by.
Of course not.
The whole aim is to build rapport.
Top right is confidentiality. And the slide uses this phrase I like. Acknowledge the burden of trust.
I've always liked that phrasing too. Patients are entrusting you with private information they may never have told anyone before. You have to treat that with respect. You have to acknowledge that burden explicitly.
Bottom left is time. It warns you not to appear rushed. But it also has a really practical tip for hospitals. Be courteous of word schedules like meal times and rest periods.
Nothing destroys rapport faster than waking someone up from a nap to ask about their bowel movements. It's basic respect.
Right. And finally, self-presentation. It lists dress, hygiene, name badge, and it says to adhere to hospital codes like sleeves rolled up, minimal jewelry, clean nails.
And that's functional infection control,
Yeah.
especially the sleeves and nails. But it's also psychological. You want to look professional, disciplined.
And slide 5 takes this physical setup even further. Positioning for connection. We have 2 diagrams here, optimal versus suboptimal.
This is all about power dynamics and barriers.
Let's look at the suboptimal image first. It shows a doctor sitting behind a big desk, patient on the other side.
The fortress approach. The slide notes that this places an additional barrier between you and the patient. It creates this dynamic where you're the authority figure and they're just the subject.
And the optimal arrangement on the left.
The chairs are arranged in a triangle or on a corner, no desk in between. The text says you are physically closer without any barrier. It signals partnership.
And there's a specific note at the bottom about bedside etiquette.
Crucial for when the patient is in the hospital. It says, sit in a chair, not on the bed.
Don't sit on the bed.
It's an invasion of personal space. But more importantly, sit down. You want to get to their eye level. If you're standing while they're lying down, you're literally looking down on them.
Okay, so we're seated. The room is quiet. We look professional. Now we actually have to talk. Slide 6 is titled Guiding the Narrative. The questioning funnel.
The funnel. This is the classic visual for history taking. It's wide at the top and it tapers down to a tiny point. It shows the flow of the conversation.
And the top, the widest part, is labeled open-ended questions.
This is how you have to start. The whole purpose is to allow the patient to shape the narrative. The examples are things like, can you tell me more about that? Or tell me what's brought you in today. You want them to paint the picture first.
Because if you start with specific questions, you might miss the big picture.
Exactly. If you start by asking, does your chest hurt? They might say no, because what they feel is actually pressure, not pain. If you start with, tell me what you're feeling, they'll describe the pressure.
So once they've told the story, you move down the funnel to the middle section, directive questions.
This is where you add the detail. Where exactly is the pain? When did it start? You're taking their raw story and starting to organize it.
And at the very bottom, the narrowest point, closed-ended questions.
The yes or no questions. Did you actually pass out? Are you allergic to drugs? You use these to nail down specific facts, but the slide implies you do this after the narrative is out.
Right. If you start here, it's an interrogation. If you end here, It's just clarification.
Precisely.
Okay, so slide 7 gives us a cheat sheet. Top 10 technique tips for a successful consultation.
Yeah, there's a lot here, but let's pull out a couple that might not be obvious. Number 5 says, steer talkative patients towards relevant facts.
Which is a polite way of saying interrupt them gently.
It's a real skill. You have to guide the conversation without being rude. And number 7 is also vital. Clarify the meaning of any lay terms or diagnoses patients use.
Like if a patient says they have the flu.
Exactly. You need to ask what that means to them. Do they have a runny nose or are they vomiting? Don't assume you speak the same language.
And I really like this practice point box at the bottom about taking notes. It says, say what you are writing as you write it.
Yes. This addresses that awkward silence problem. If you just stop talking to write, the patient thinks you've disengaged. But if you say, okay, I'm just writing down that this started on Tuesday,
It validates them.
it validates them, they know you heard it, and it keeps the whole flow of the conversation going.
All right, let's shift gears from how to ask to what we're recording. Slide 8, structuring the story, the sequence of a medical history.
This diagram is a staircase showing 10 distinct steps, and the header makes a vital point. While your conversation style is fluid, the final record follows a consistent and logical structure.
So you don't write it down in the chaotic order the patient said it. You reorganize it.
You have to, because another doctor needs to be able to read this at 3 in the morning and find the information they need instantly. That has to be standardized.
So we have the basics at the start. Source, ID data, chief complaint. Then the big one, HPI, or history of present illness.
And then all the background context, past medical history, drugs, allergies, social history, family history, and finally, the review of systems.
It's a roadmap. So let's deep dive into the most complex part of that map. Slide 9, mastering the history of present illness, HPI.
This is the masterpiece of the chart. The slide defines the HPI as an organized, edited description of the patient's current illness, written in a chronological, linear fashion.
It emphasizes the word edited. So you are the editor of their story.
You're the curator. You take the raw footage and you turn it into a documentary.
And the slide lists key elements. We have the narrative setting, timing, quality. But there are these two terms I find fascinating, pertinent positives and pertinent negatives.
This is the real detective work. Pertinent positives are the symptoms related to the system that are actually present. You know, the patient has a fever, positive finding.
But pertinent negatives are defined as expected symptoms related to the involved organ system that are absent.
And the slide says this is crucial for ruling out competing hypotheses. Think about it. If you come in with a sore throat, I expect you might have a cough. If you tell me, I have a sore throat, but I have no cough.
That's a huge clue.
It's a massive clue. It points me away from a common cold and maybe towards something else, like strep throat.
So documenting what is not happening is just as important as what is.
Sometimes more important, it shows you looked.
Okay, slide 10 groups the background context. Building the complete clinical picture. This covers past medical history, or PMH, meds, and social history.
For past medical history, it's the usual: chronic problems, surgeries. For medications and allergies, it puts all L in capital letters. You have to include prescribed drugs, over-the-counter medications, and alternative therapies.
People always forget that herbal tea or vitamins count as medication.
Always. And for allergies, the slide says to clearly describe the specific reaction, not just allergic to penicillin, but how, rash, swelling.
Anaphylaxis.
Right. And then social history. This is the life context.
Work, stress, living situation.
And specifically substance use. The slide lists the CAGE questions for alcohol screening.
Let's spell those out.
It's an acronym. CAGE. Have you ever felt the need to cut down? Have people annoyed you by criticizing your drinking? Have you felt guilty? And have you needed a drink first thing in the morning, an eye-opener?
It's a very efficient way to get at a sensitive topic without being accusatory.
It hits the behavioral markers really quickly.
All right, slide 11 is tracing the pattern, the family history. And we see a diagram here called a genogram.
The family tree. The slide gives us the rules for drawing this. Squares are male, circles are female. A diagonal line through one means the person is deceased.
And if someone has the disease we're looking for.
Use a solid fill. You basically black out the square or circle, and you use an arrow to point to the prepositus, which is just the fancy term for your patient.
And the goal here is to identify hereditary patterns and risk.
Right. If you see filled-in circles in every single generation, you instantly think about genetic inheritance. It visualizes the risk for you.
Okay, slide 12 is the review of systems, or ROS. It's a big table of body systems. General, heat, cardio, respiratory.
This is the safety net. The slide calls it the final check. You've done the main story, the family, the social. Now you systematically sweep the body to ensure nothing important has been missed.
Do you have headaches, vision changes, chest pain?
Exactly. Because sometimes a patient is so focused on their knee pain that they totally forget to mention they've been having night sweats for 3 weeks. The ROS catches the things that don't fit into the main story but might be critical.
And the slide has a bold reminder here. Remember, these are symptoms, not diagnoses.
Right. You record shortness of breath. You don't write asthma. You're recording what they feel, not the label for it.
Okay, so we have the theory, we have the funnel, the environment, the structure. Now let's see it in practice. Slide 13. Putting it all together. A sample history.
A case study. Meet Mr. Jones. The slide introduces him as a 72-year-old retired farmer.
And his chief complaint is, I faded 3 times in the last 2 days.
Okay, now look at how the history of present illness is written in the sample. It starts with a baseline. He was in his usual state of health.
Which allows him to lead a fairly active life. Then the event. 2 days ago, in the kitchen making a sandwich, he felt dizzy and found himself on the floor.
But here is the gold. Look at the bold text in the middle paragraph. Prior to losing consciousness, he did not experience a headache, chest pain, palpitations, or shortness of breath.
Those are the pertinent negatives we just talked about.
Exactly. The doctor specifically asked about those things. By recording that they were absent, the doctor is signaling, I checked for a heart attack, I checked for a stroke, and the patient says no.
The history goes on. Another episode watching TV, a third one getting out of bed.
And look at the very end, the impact statement. He still likes to ride his tractor, but is afraid to since these episodes started.
That brings it right back to the human element. He's not just a fainting body. He's a farmer who's scared he can't do his work anymore.
And slide 14 helps us understand why this is a good history. It's titled Deconstructing the Expert History, and it draws lines from the text to the reasoning.
It points to the dizzy comment. The text notes, he had vertigo in the past, but that was very different from his current dizziness.
And the analysis arrow says this clarifies ambiguous terms by contrasting with the patient's past experience. Dizzy is an ambiguous word. By contrasting it, the doctor has clarified that the room isn't spinning, he's lightheaded. That changes the entire diagnosis.
And it points to the pertinent negatives, that lack of chest pain.
The analysis says, excellent use of pertinent negatives to help rule out cardiac or neurological causes.
And finally, it points to the tractor comment as demonstrating understanding of the illness's impact on the patient's life.
It shows that the doctor listened. And, practically speaking, if you cure his fainting but don't get him back on that tractor, you haven't really solved his problem.
It really shows that following the structure, the symptoms, the negatives, the impact, it actually tells a complete story. It's not robotic at all.
That's the art part of the title. The structure is rigid, but the result is a detailed human portrait.
We have reached the end of the slide deck. That was the last one, slide 14. We went from a simple stethoscope drawing to Mr. Jones's tractor.
We covered a lot of ground. We built the environment, that triangle of chairs. We learned the funnel, open to closed questions. We built the roadmap HPI, PMH, ROS.
It's an alphabet soup of acronyms, but I can see how they function as a safety net.
Looking back at that very first slide, that phrase, first therapeutic act, really sticks with me. The final thought for me here is that the structure, this rigid list of questions and categories, it's not there to restrict you. It's there to free you up.
How do you mean?
Well, if you have to constantly worry about what do I ask next, you can't really listen. But when you know the map, when the structure is second nature, you don't have to stare at the compass. You can look at the patient. You can hear the fear in Mr. Jones's voice about his tractor. You can catch the nuance between dizziness and vertigo.
The science of the structure is what allows the art of the connection to happen.
That's the crux of it. The checklist supports the empathy. It doesn't replace it.
Well, class is dismissed for today. Thanks for walking through this slide deck with us. Hopefully the next time you're in a doctor's office, or if you're the one holding the stethoscope, you'll see that conversation in a whole new light. It's not just a chat, it's a strategic investigation.
Absolutely.
Thanks for listening to The Deep Dive. See you next time.
For deeper understanding and focused preparation for your final MBBS exams, you may refer to Essentials of Medicine, a bedside approach.